Welcome to the Health Equity Network webinar. My name is Alan Higgins. I'm the Health Equity Network lead, and we're particularly pleased today to have a presentation on structural racism, ethnicity, and health inequalities in London. And Jessica, if you'd like to start loading up your slides now, then while I do the introduction. The monthly webinars are a key feature of the way the network functions. And if you've been on them before, you'll know that they're fairly informal, and we usually work with a theme and then a couple of presentations, and then we allow about half an hour for people to ask questions, engage in discussion. The usual rules apply on webinars, so that if you're not speaking or asking a question, if you can stay on mute, that would be really helpful. And but otherwise, we do wish to encourage people to engage in discussion. The webinar will be recorded. Hopefully that's okay with everybody. And then it'll be made available on the network platform afterwards. This is a particularly busy period for the network. We had a conference in Belfast in September. We had our annual conference in Birmingham about 2 weeks ago. And we're looking forward to another conference in Scotland, in Glasgow, in November. So we're delighted that so many people are joining. Hopefully, if you can, you could join us in Glasgow as well. The registration for that will be going up shortly. On to today. So I'm delighted that we have two speakers. The theme is structural racism, ethnicity, and health inequalities in London, which is the title of a report produced by the Institute of Health Equity a week or so ago. Whilst it was commissioned by the Greater London Authority, it has relevance for the rest of the country as well, and we're delighted that so many people have been keen to sign up for the webinar. Dr. Jessica Allen, Deputy Director at Institute of Health Equity, is one of our presenters. We're delighted as well that Professor Habib Naqvi, who's Chief Exec of the NHS Race and Health Observatory, is also presenting. Habib, of course, has been involved in this work from the outset as co-chair of the advisory board and as a very active member of the advisory board too. The way that we'll structure this, because Habib has to leave to join another meeting at around 1 o'clock, is that Jessica will present and then hand over to Habib. After Habib has finished his slides, we'll allow a pause at that point just to see if there's any questions, particularly about the healthcare aspects, and then Jessica will come back in to develop the presentation on structural determinants and recommendations as well. So hopefully that's okay with everybody, and I'll hand over to Jessica to get going.
Great, many thanks, Alan. I'm delighted to be here to see so many of you, and from the chat it looks like you come from a wide range of different sectors and organisations, which is fantastic. Delighted to see so many of you of such a range as well. So please do use that QR code if it's working. Hopefully it is. If not, on our website, this report. Today it's a long and complex report with an enormous amount of information and analysis in it, and we're only able to give a very brief overview today. So please do, if you get the opportunity, take a look at the report. There's an executive summary, but the main report has an enormous amount of detail and examples of good practice. I would really encourage you, please, to read that. I think there's a lot more in there than we can talk about today. So as Alan said, the review was funded by the GLA, very welcome. They've taken a strong lead on tackling structural racism, acknowledging and tackling structural racism, and wanted to really understand the impacts of structural racism on health and health inequalities in London. And for us to work with them and with many other stakeholders to develop recommendations for action. Really important that we have these recommendations for public health, but actually they go way beyond public health to all those sectors and organisations that have an impact on health and can do more to tackle racism. We think that this has relevance also outside of London. London has a specific demographic context and has taken a leading role in developing anti-racism approaches, but there's a lot there, we think, for the rest of the UK and potentially beyond. So we begin the report by summarising really the extent of racism. It's widespread and it's persistent, and it causes damage to individuals, communities and society as a whole. And we're very clear in this report, building on the work of many other organisations and people about that. And if you do get a chance to look at the main report, the amount of evidence and reports and analysis that we present really is testament to how widespread damaging racism is, even so in London, despite efforts. And of course, its impacts are experienced in different ways. Really important to point out, it's a very complicated picture, and you cannot just draw the inference ethnic minority group experiences racism damaging to health. There's a very complicated series of contexts, different ways of experiencing discrimination, a socioeconomic position, of course, a major driver of exclusion and poor health outcomes, interrelationships with ethnicity, experience, migratory experience, other dimensions of exclusion. So we make that point, we hope, in the report very clearly, that this is a complicated picture intersecting with all those other conditions and experiences in life. As Alan said, I'm going to hand over now to Habib to talk through health outcomes and experiences with health and social care systems. And Habib, if you just ask me to move the slides on as needed, I'll do that.
Wonderful, thank you so much, Jessica, and thank you so much, Alan, as well. And just as been highlighted just now, the fact that we've got a widespread of people from different sectors is really critical, because race and racism is a global system-wide challenge that requires a global and system-wide response. And I've been absolutely delighted to be involved in this work and to co-chair the advisory group with Sir Michael Marmot, because we know that racial inequalities in health are unjust, they're immoral, and they're wrong. And they're wrong because, in the main, they're avoidable. And what this report does is highlight exactly where racism intersects with different parts of society, the different social determinants of health, and in particular in relation to health care. The next slide highlights how, when we look at the impact of racial inequality on health and health care, we focus on, of course, access to healthcare, the experience of healthcare, and outcomes in health. And life expectancy is one of the outcomes of that particular relationship. And it's a complex picture when it comes to life expectancy. We know that there are current estimates around life expectancy by ethnicity, and various organizations highlight those on a regular basis. But that complex picture around migration, around differential age structures and the stratification therefore that we see with regards to age, but also the socioeconomic differences, and that complex relationship between race and socioeconomic status has kind of been of much debate, particularly in recent times, and the fact that it kind of very often experimental data are used to highlight life expectancy leads to some level of uncertainty, particularly around the quality of the data, but also some of the methodological approaches used to come to the life expectancy outputs that we see. And for that, based upon that complex relationship, there is kind of, although there's extensive detailed analysis of these factors in the annex to the report, and please do read the report, but for those reasons we don't report on life expectancy within the report itself. But what we do is look at the other aspects, including, for example, the long history of inequalities that we know has existed in this country for not just for years, decades, but for many centuries. Because if you think about migration in this country, it's, you know, it dates back to a very long time, and that kind of leads to of course the richness that we see within our society and within our culture, but it also points to the very stark inequalities and the stratification that we see in health and health outcomes as well. And this chart highlights exactly that level of stratification by ethnic group, both for females and males, and the kind of percentage reporting limiting illness or disability by age and sex in London, and the groups. And if you can clearly see the Gypsy and Irish traveller as having very stark inequalities compared to other groups. But there's a kind of ongoing pattern that we see in ethnic inequalities in health for certain groups: the Pakistani group, the Black African, the Black Caribbean groups, the Bangladeshi groups as well. And that's kind of a persistent pattern that seems to come up with across a range of different conditions and illnesses. And of course, the next slide highlights perhaps what is one of the most stark inequalities that we see, not just in health, but across society as a whole. The fact that Black women are up to 4 times more likely compared to their white counterparts to die during pregnancy, childbirth, or soon after is not right today in 2024. And Asian women being up to 2 times more likely. And there is concerted work across healthcare and across the NHS to focus on this disparity, and of course the disparity not just for mothers but for infants and for babies as well. And infant mortality rate, as this chart highlights, kind of almost replicates or reflects the previous chart, in that Black African, Black Caribbean, Pakistani, Bangladeshi communities have higher rates of infant mortality than the general population. So there is a level of urgency for us to focus on this agenda. And in a way, our country, our healthcare system should be well equipped to deal with that level of urgency. But we have focused in the main on surface level solutions to these challenges, and not focused on what in fact Michael calls the causes of the inequalities that we see, not just in maternal and neonatal outcomes, but as the next slide shows, in mental health, which perhaps is one of the long-standing challenges that the healthcare system has. The challenges that have been looked at, for example, when we look at talking therapies or IAPT, access to psychological therapies, we know from the data that particularly young Black men are less likely to access talking therapies, less likely to be referred to talking therapies, less likely to self-refer to talking therapies, and more likely to find their route into healthcare through other means, such as the next slide. For example, access into mental health care through more coercive routes, such as detention under the Mental Health Act. The Mental Health Act itself needs revision. It's outdated. It came out in 1983. It was rolled out, and of course there is kind of a level of kind of racial bias within it, which leads to some of the outcomes that we see as highlighted on this particular slide itself. We know that there are issues not just in relation to health care, but also the workforce. And of course, if we are in the business of tackling inequalities in health, which we are, then we need to focus on some of the biases that are inherent, not just in the services, the policies and the processes within our healthcare system, but also in the interventions, the medical devices, the clinical assessments, as well as, of course, the medications, and the lack of representation. If you think about the causes of the inequalities, the lack of representation in research, in clinical trials that actually lead to, therefore, the development or the production of devices, of algorithms, of clinical assessments that are not always fit for purpose for the diverse communities that we're here to serve is something that we can see clearly and vividly. Pulse oximetry is one example that we saw during COVID-19. The fact that if the darker the color of your skin, the less accurate the readings are likely to be from pulse oximeters is a critical point, particularly during a pandemic that was affecting the level of oxygen in people's bodies. The APGAR score, judging the health of a baby minutes after its birth, partly based upon the color of its skin, was not right in 1952 when the APGAR score was rolled out. Certainly not right today in 2024. And of course, the APGAR score, like many interventions developed in this country, has been rolled out to other parts of the globe, including in parts in countries in Africa, which of course raises concerns at a different level altogether. And then, of course, medications. We know that there are anti-cancer drugs that do not get broken down as quickly in black bodies as they do in white bodies, have led to higher levels of toxicity. And of course, the lack of representation in clinical trials leads to some of the biases that we therefore see in these interventions. And of course, we also need to focus on the NHS as an employer. Because if we are to tackle health inequalities in a sustained, meaningful way, then we need leadership that's reflective of the communities that we're here to serve. And yet we know that there is lack of progression within the workplace, within the NHS, particularly for Black and ethnic minority staff. We know that there is differential experience within the workplace with regards to bullying and harassment, victimization, not just from patients and the communities, but also from staff and managers and leaders as well. So there's a lot of work to be done to tackle racial inequalities in health and in healthcare, both for our patients and communities, but also in terms of our workforce, because we know that an engaged and fully inclusive workforce at all levels leads to better outcomes for all patients as well. So I guess on that note, I'll pause there, Jessica and Alan, and hand back to yourselves. And I think there may be some time for questions at this stage.
Thanks very much, Habib. Excellent. Yes, we're going to pause here for a moment. Habib has to leave at 1 o'clock. Any questions or comments about the information so far, particularly relating to health and social care services? If you can use the raise hand facility, then we can take a point or two now. Go ahead, Jirina. You're first up.
Thank you very much, Habib, and thank you, Jessica, as well, for the introductions. It's just really, I think we hear this, and every time you hear it, it's like you're hearing it for the first time because it hurts that much. So, but anyway, you can never hear it enough. My worry for me is that I don't think we ever have the right people in the room, and I don't know how we can get the right people in the room. By that I mean the policymakers, the game changers, so that they can hear this information, take it away, see the reactions from people, I guess like me and others who, yourselves, Habib, speaking out, saying these are the concerns, because really, otherwise, I worry that we can keep going on and on and on, and then really there's no change, particularly around structural racism, that within healthcare, because it all stems around recruitment, the policies that they're making. So what more can we do so that we can get those right people in the room, so that the change can happen, so that they can really be accountable for these things that are continuing to happen. Thank you.
Thanks, Jirina. Habib, Jessica, would you like to respond?
I can begin, if that's okay, with a response. Absolutely right. Leadership is critical for change and accountability. But at the same time, I always say that for there to be any change in any sphere or any part of this agenda, there needs to be an acknowledgement that there is something to change. And when there is an acknowledgement around race and racism, we will not get the sustained approach to tackling these deep-seated issues in a way that will be long-lasting. We'll get surface-level solutions, but we will not be able to focus on the causes of the causes, which of course include the impact of racism, not just on health, but also on the social determinants of health, which I think Jessica will focus on a little later on, and focusing on things such as, for example, the ethnicity pay gap within our, focusing on the learnings from COVID-19 around how we need to engage with our communities in a meaningful way over time. So leadership is important, and tighter levels of accountability as to what people do and tackling it when they don't do what they should be doing is absolutely critical. But the main point here is that people, the government, the NHS have their kind of their moral compass pointing in the right direction.
Thanks, Habib. Thank you, Jarina, for the question as well. We're going to take 2 questions, Habib, if you don't mind, and then you can respond, and then we'll take 2 more questions. So Sharon, would you like to go up first? Sharon Burke.
I'd just like to ask, increasingly local authorities are saying we are going to be a marmot city, and they produce whole rafts of nonsensical papers, really, lots of words but very little substance, and then they pretend that they are a marmot city. I just wondered if you had a view on that, or how you could perhaps tackle that. So they want to become a marmot city, but of course none of the local authorities have any racism, which I'm saying that with my tongue firmly in my cheek. So nothing is changing, exactly what you just said.
Thanks, Sharon. And if we can take the next question, and then I'll invite Jessica and Habib to respond. So Rosie Murphy.
Yeah, it was just really to sort of ask to your experience, really, Habib and Jessica. I still very much feel like there's huge variation in terms of different organisations, whether that be local authority, NHS trusts, in terms of the extent to which they accept the existence of structural racism. And I still feel that we're really very much living in the shadow of the Sewell report. And I just wanted to ask the ways in which you communicate the sort of your position statement, really, on how do we navigate forwards with the Sewell report having been so recent, and I suppose try to navigate the variation across those different organisations. I feel like I expend a lot of energy sort of trying to establish where do we stand, what's our position on this, and I just wanted to tap into your wisdom in terms of navigating those conversations, really.
Thank you. Would you like to respond to both those questions? First about the marmot cities, and then
shall I respond to the marmot cities, and then perhaps so Sharon, probably won't surprise you to know that as the Marmot Institute we have a more positive view of the impact of the work that Marmot Places have been doing, and we're currently doing a stock take and an assessment of just what's been happening, what that impact is, and drawing lessons from that. But it's absolutely right to point out that there hasn't been a good focus, I think this is true of public health generally, on racism and its impacts on health. My understanding is that part of the reason for this commission was to try and strengthen that, to provide the evidence, to propose ways forward, to encourage local authorities, public health systems, as well as national organisations to really embed and take action on structural racism. So I think this report was commissioned with that intention, and Kevin Fenton, who's the Regional Director of Public Health in London, among other roles, has explicitly said that this report, he hopes, will contribute to an increasing awareness among public health folk and across local authorities and Marmot Places, that this is a really vital and essential approach that needs strengthening. So I agree, we're not there yet, but we're pushing forward on this, hoping that this structural racism, all the evidence that we've presented, is taken up by local authorities and public health more.
Thank you. Habib, would you like to respond to the second question?
Yeah, absolutely. Yeah, Rosie, you present an excellent question, and one that we tackled within my organisation at the NHS Race and Health Observatory quite early on. The fact is that very often interventions on this agenda have been fragmented, costly and confused. And the Sewell report is perhaps an example of that. And in fact, we pushed back very strongly on the findings and the points raised within the Sewell report at the time, and have a response which was a rapid evidence review based upon data. You know, we do not get involved. We should not. People should not get involved in culture wars, but should base their assertions, their recommendations, their views on what the data tell us. And the data tell us very stark inequalities, just as the slides have shown so far. And there's another point here around trust. And trust is about, I define trust as truth told consistently over time. And when there's a breakdown in any part of that algorithm, whether it's truth or the consistency of the truth or over time, there's a breakdown in trust. And so there's much work to be done now to build and rebuild levels of trust and confidence with our communities, our patients, and our staff in the healthcare system, particularly over the last few years. So, you know, I'm confident that now, as we move with a new government, a new mandate, that we will be able to hopefully focus on truth and make sure that we have that engagement over time.
Thank you very much. Ahmed Hussein, you've been very patient. Go ahead, please. One last question, this is.
Sorry, is it me, Hussein?
Yes, it is.
Yes. Hello, everyone. My name is Hussein. I work as a refugee support for a community, call it, name it Community Together in Tamworth. I was dealing like for the last 1.5 years with a complete an asylum seeker accommodation in here, which they was like accommodating more than 250 people. And I had a lot of like cases for racism, like the guys was being like beaten up in the streets, and then they was going to hospital. So my question is the NHS in the hospitals, when somebody, any cases like goes to them with a racist accident, if this patient like not an English speaker, is the NHS or the doctors that following up or like directing this person, this is what should be happen, now you have to report, you can go to the police? Because many of these cases, when they was coming back from the hospital after like being treated very badly, they was telling me that they have no idea what they was being told. They have only given them this paper, a piece of paper, which of course like the report after what's happening to them. So I was thinking as a question, like if there is a communication between the NHS and the police for special cases when it comes to the racism against the immigrants, because these immigrants, they are a non-English speaker. So sometimes like you just see in a hospital, someone is coming inside covered in blood. He don't speak English. However you ask him, you don't know what's going on. So
Thanks,
like
Hussein.
this kind, you're welcome.
Yeah, go ahead, Habib. Great question.
Well, yeah, very good question, very pertinent. I don't have the answer to that right here, but there will be guidelines. There's a very close relationship between the NHS and the police as well, particularly when it comes to racial abuse. And there's a zero tolerance around any form of abuse, including racial abuse within the NHS and, of course, with the authorities. So I apologise that I don't have the answer right here, but there will be guidelines, I'm sure, on the NHS website.
Thank you. Thank you for that question, Hussein. Well, thank you very much, Habib. So pleased that you could join us for the webinar today, and thanks for your ongoing input to this discussion. So we'll carry on now with the remainder of the presentation with Jessica, and then we'll be able to take more questions and comments. Jess.
Thanks, Habib. Thanks, Alan. So the process of developing the report, we began with a much briefer remit, really, to do a short analysis. But then GLA held a consultation with community groups who said that wasn't extensive enough, and they wanted to see more, and particularly more evidence brought in about what's working, what community groups are doing. So we responded to that and expanded the group, and they also requested that there was more input from community voluntary sector organisations, from people with lived experience, and we established an advisory board which covered those sectors, and that's been a really helpful part of the process, a very expert and helpful and supportive advisory board who shaped a lot of the work actually and had significant input. We used the Marmot framework to try and establish how racism impacts on health and the pathways through the social determinants. And the Marmot framework is a set of areas, social determinants of health areas, which are the key shapers of health, key drivers of health for all of us, but how those are impacted by racism, and then obviously into healthcare services, as Habib has just aligned. We looked at the data. Now, of course, the data on racism is either non-existent or extremely weak. So we use data around ethnic outcomes where it's available, and again, it's not nearly extensive enough, and those social determinants of health. And we used reports and accounts of racism. There are many, many reports and accounts of racism in all the areas which we touched on, and we tried to draw on those to point out the areas which aren't represented in the data systems at all, where racism operates, how it operates. But again, we realise that that's a fraction of the racism that's actually experienced, because so much goes unreported and unacknowledged and ignored and overlooked. So it's just, we accessed what we could, understanding that there's an enormous amount that we couldn't access or report on. And the Race Equality Foundation have held a long consultation with the community sector on the report, on the recommendations, and are developing a set of recommendations, specific recommendations directly from people with lived experience and those community groups. So the process is ongoing, and certainly we're, now the report is finished, we're talking where we can and bringing our analysis to the areas where we work to really embed that anti-racism approach, we hope. So these, we focused on the six of these social determinants of health, from giving every child the best start in life, so the early years, through to education and experiences of young people more broadly in relation to employment, skills, training, as well as education, fair employment and good work for all. So unemployment is very bad for health. Good quality employment is obviously good for health. Pay, income, benefits, levels of poverty, healthy and sustainable places in communities. So here we cover housing, air pollution, the urban environment, access to green spaces. And in this report, we cover the criminal justice system, a long-standing, obviously, body of evidence about racism, especially in London, police force, the whole criminal justice system. And sixthly, the role and impact of ill health prevention, that's inequalities related to smoking, alcohol, obesity, and drugs. So the main focus of our report are these six social determinants of health, in addition to the areas which Habib's just reported on, health and social care system. We know that there's racism is increasing in London. This is from the survey of Londoners, and you can see percent of Londoners who reported being treated unfairly in that survey, 2018 to 29 in pale green, and the dark green bar at 2021. So that's increasing. And obviously the events over the summer, the appalling racist fueled violence across the UK adds additional weight to this feeling that racism is increasing. In some respects, in London, the diversity, the demographics of London, the experience of long-standing immigration means that there's different attitudes, and in fact, to some degree, more tolerance towards immigration than there is in the rest of England. Obviously, it's in one respect, that's encouraging because it shows that greater integration, greater diversity of a population supports greater tolerance. But then I counter that with the previous evidence showing that racism and discrimination based on ethnicity is actually increasing in London still. So giving every child the best start in life, Habib showed the appalling inequalities in maternal and infant health. And this slide, we know how important it is to eradicate child poverty, to give every child the best start in life. But you look at these enormous inequalities in child poverty across London. So already too high. You can see the England average, 30%. This is after housing costs, before a bit lower. London, higher rates of poverty than England as a whole. And you can see these absolutely staggeringly high rates among Pakistani and Bangladeshi children in London, nearly 70% in both of those, much lower rates among Chinese, white and Indian. And those, you'll see Chinese, white and Indian ethnic groups having much lower rates in lots of the areas that we cover. But this is a particularly horrific data really showing these extraordinarily high rates of child poverty. In the report, we go into greater detail about differences in early childhood development experiences in early years and so on, but I'm just only able to cover a few highlights or the few most shocking parts of the data that we are key findings that we pulled out for this presentation. So some relatively good news, I guess. Across London, there are better educational and learning outcomes than there are in England. And you can see, and the ethnic inequalities are lower and have changed over time. And you can see here that Asian children have particularly high rates of meeting the expected standard of reading and writing, but most children in London are exceeding the English average. So that's testament really to the work done by schools and families across London in trying to improve attainment generally and reduce inequalities by ethnicity. Unfortunately, the difference for children in poverty and those not in poverty is very stark still. This is in England. We couldn't get this data for London, but you can see for most groups, Chinese accepted a bit, those who are eligible for free school meals have the dark green bars have much lower levels of reading, writing, maths at Key Stage 2. Gaps are particularly wide for white British children and some of those others, but almost closed here among these communities up here. Bangladeshi, very high rates of children, even those children in poverty on free school meals, very high levels of attainment. And then when we turn to inequalities at age 16, you can see again London performs a bit better than England overall, but there are some groups which unfortunately are not benefiting from that London advantage anymore, and that some of those inequalities have really widened by ethnicity, particularly for Gypsy Romas, travellers, Black Caribbean. Many of the Black ethnic groups clear that schools are not meeting their needs adequately, and those inequalities are beginning to widen. They're still less in London than in other areas, but concern as children are and students are going through school. We move on to employment, and you can see here that the advantage that many children have had in education, particularly Pakistani and Bangladeshi, does not translate into better employment rates. So this is a particularly shocking picture, I think, being shown that while there are progress made in education, that's really falling away when you start looking at employment. And there's a big job for employers in London to do to scrutinise their own practices and do far, far more to reduce those inequalities in ethnicity. So in employment, you can see Irish, Chinese, mixed white, Asian, Indian, white, British, all doing better than average in relation to employment. And some of those groups which were doing so well in education, much lower employment rates. And pay, similarly. You can see Bangladeshi, Pakistani, Black Caribbean, Black African, doing well in those early years in school, doing well throughout school, but not getting that advantage in employment and not having decent rates of pay at all. So again, a big challenge to employers across London in understanding, appreciating, acknowledging and addressing those ethnic inequalities, and that can only be down to bias, racism within employment. There are so many reports and accounts of racism in employment. It's not substantive enough, it's not systematic enough, but we know it's there and it really needs to be addressed. And of course that all translates into poverty. I've shown you the poverty rates among children, those appalling statistics, but much higher rates of ethnic groups, black, mixed, other groups who can't keep them. This only runs to 2022, they'll have increased. Again, these inequalities in food poverty, and food insecurity, and you can see here the absolutely appalling impacts of changes in cash benefits. So this is changes in welfare payments, and it's really hit black, other mixed families much harder. There have been cuts across the board, but these enormous decreases in what black families across across the UK were able to access. And we know, and it's in the report, the inequalities in wealth, in household ownership, and so on by ethnicity across the UK. Healthy and sustainable places, housing, many reports and accounts of racism within housing providers, from private rentals, social housing, housing associations, the death of the young child Arab Ishaq in Rochdale, and the treatment that family received at the hands of the housing provider, one of those reports, but there are many more. And you can see here private rental, black families reporting that much more infrequently that their housing is of decent quality, and also much more likely to be in overcrowded housing and all the health impacts of both of those. And we know much lower rates of home ownership. And I mentioned some of the other areas that we cover in this report, but living in areas of higher air pollution, less access to green spaces, and I haven't provided the information on this presentation, but the treatment at the hands of the criminal justice system and the feelings of lack of feeling safe, the unwillingness to go outside because of issues of safety, travel on public transport, all these areas which we know are so important for health, and these differences by ethnicity, and really the lack of protection offered by the criminal justice system in London, high rates of incarceration, stop and search, etc. So again, we do cover that in the report, and it's been covered well elsewhere as well. But really, the Met Police failure to take up those recommendations which have been repeatedly made to them, absolutely appalling. So to summarise and move on to the recommendations, we've identified so much good practice happening in London, usually at insufficient scale, short-term funding, community and voluntary sector organisations trying their best to provide support services and support communities in hugely challenging circumstances, and where there's evidence that these are having such a positive impact, the funding falls away after a short time, and I'm sure many of you have experienced that. So we talk about the need for commissioners to be more sensitive and aware of the differences in evidence that organisations can provide, making the application process easier and so on. Overall, though, the recommendations are quite high level, directed at those system organisations, and the intention is that those organisations respond and take up the recommendations and the analysis and make them specific for their own organisations. We couldn't do detailed recommendations for every part of the system and organisation that we covered. And if you think about the cumulative impact of all of those inequalities that we report on in the report, and that many of you will have much greater detail on, I think it's that cumulative impact overall where we need the system-wide response and more direction, and focus on legislation, regulation, the legal mechanisms, and so on. But we focus on those structures and on institutions, and particularly on public health and the health system, but others as well. So the recommendations that we make are general in that, for example, we talk about the need to reduce child poverty. That applies to everybody in London, or all those children experiencing child poverty, but with a particular focus which is proportionate to the scale of the issues faced by particular ethnic communities who are much more likely to be in poverty. and the way that support service and mitigating efforts need to be proportionately directed in a much fairer and better way to meet the scale of the challenge. And services generally need to be much more responsive to the different circumstances and needs of differing ethnic communities and the positions that they're in. And providing a universal service is great, but not when it's insensitive and culturally inappropriate and racist. You know, Habib pointed out some of the issues with the NHS services. So it needs that flexibility and that more proportionate, culturally appropriate approaches. The recommendations, I haven't covered them all here. There are lots, and they're all in the report. And as I say, the Race Equality Foundation working with community groups to go through those and make them relevant to specific organisations. But in general, we talk about public health needing to take a much greater leading role in highlighting the impacts of racism on health and in those social determinants of health, and working with organisations within the places where they operate to put racial equity at the heart of policy and interventions. Spending and resource allocations must be proportionate. So it's all very well having that understanding and making the case, but you actually need resources to be allocated in a proportionate way to meet the challenge of mitigating the impacts of racism, as well as challenging organisational and systemic racism. Services must be culturally appropriate and designed with minority ethnic communities. Again, a strong feature that we heard repeatedly is the need for the much greater involvement of communities with lived experience and those community voluntary sector organisations to be at the heart of the design and delivery of programmes and policies. There must be effective access to combat racism. There's a glaring lack of accountability and sanctions, even when racism is reported in many organisations. I'm thinking particularly of employers, but also service providers. And it's difficult to report it, and the onus is often on the individuals. But even when it is reported and someone is able to stand up and make that case, there's often no sanctions, no accountability by anybody, and it's no wonder the trust breaks down at that point. So that is a really important point. It's all very well having good intentions and strategies and so on, but without accountability and sanctions, I think it's ineffective, certainly not strong enough. And appropriate data and evidence, I've said that we've lacked data and evidence. Certainly in London there's more, but in other areas there's much less. We really need it to identify the issues, to make the case, to design appropriate services, interventions and appropriate programmes, and to really challenge, as someone pointed out earlier, the policymakers so that they cannot avoid this. And of course, understand what's effective and what's not effective. So that's a very brief overview. I do hope you are able to find time to go through the report, which has a lot more detail and context around it. But we really do, I think, try at least to make a very heartfelt cry for urgent action on the evils of racism and the impacts that it's having on the lives and health of affected communities. Thank you.
Excellent. Thank you very much, Jessica. There have been a lot of points made in the chat. I encourage people to raise their hands and come on and ask the question. Dominique, go ahead.
Hello there. It's a pleasure to be with you here today. Pleasure to hear the work that you've been doing, and thank you so very much for the thoughtfulness of these principles. Think that they're really on point. I'm a doctoral student here in London, a transplant from the US, and I was curious to know more about the investigation itself, and I'll certainly go and spend some time with the report as I'm coming in new to the conversation that you all are having here today. But I'm really curious about whether or not the evaluation of systemic racism looked at the healthcare system design itself, and specifically the focus on health equity as advanced through only Western allopathic means, versus including the broader scope of culturally relevant or holistic services, which may increase trust with communities from diverse backgrounds and also could create continuity of care. That's something that my research I'm hoping to eventually get to, but I got too excited and I wanted to ask, have you all looked at that? Have you looked at the system design itself and the potential for expansion?
Somewhat, probably not in the depth that you are looking at it in your thesis. And it'd be interesting to have that conversation in more detail with you. So we did look at how culturally inappropriate some services are, and particularly how they don't take account of differing levels of risk for different diseases. So in the report, we spend quite a lot of time going through the differential risk of disease and rates of mortality by ethnicity, and there are very different patterns. So, for example, some ethnic groups have much higher mortality and rates of illness from cardiovascular disease, diabetes. You'll be aware of all of this, and services are just very ill-equipped, not set up at all to take account of those differing risks. And I think really a big program is needed to make services much more aware of the differential risks and the differential needs within those services, because otherwise this pattern is going to continue. So to that extent we do, and I think Habib talked about the inappropriateness of sub-specific treatments, diagnoses, increasingly technologies, AI technologies, which are based on historical algorithms and so on. So it is, to some extent, I think it's there if that's what you meant, but it would be interesting actually, and especially I think Habib would be interested to have further discussions about, you know, how the health service in London should really, and more broadly, should respond.
Thanks, Dominic. Thanks.
Thank you.
Excellent. Katie McKinnon.
I have a slightly broader question about, I'm concerned about reports coming from America that they're growing anti-DEI pushback and impacts on funding and for research on the impacts of racism in health, to the point where some funding bodies are reportedly, after supporting work like this, are encouraging people to stop using the word racism. And just as a big body doing work, have you started to feel that? Is that pushback coming with the growing far right in the UK, and what can we do to stop it?
Well, we haven't felt any pushback, but when we were, I think, and when we were looking at organisations developing anti-racism strategy, and at the time, and I think it's changed actually with the change of government, but the anti-EDI movement, who were saying that this was all a waste of time and money, and we were thinking, actually, I talked about the accountability, the sanctions, the need for far greater strategies and leadership, capacity within organisations. It needs strengthening massively. We would feel, I think, many EDI strategies are a bit tokenistic and a bit weak and need to be strengthened enormously and much more out there, explicit and with proper clout, rather than going the other direction. We haven't yet, I mean, we only published, I think it was 2 or 3 weeks ago, so we haven't yet had any pushback at all. In fact, it's been well received, I think, so far, this work that we've done. But I agree that there is a very strong pushback more broadly on that.
Thanks.
Thanks very much. There aren't any more hands raised at the moment. Seiku, I was prompting you to come in to ask a question about asylum seekers and migrants. While you're thinking about that, please, let's go to Derek.
Hi, yes. I'm Derek Tanner. I work for the Black Southwest Network. We've just recently run a health and social care accelerator, and I really focused on enterprise. And when I'm looking at your report, and I've been around a long time, I've probably heard some of the findings over decade after decade after decade, but when you really look at it, not a great deal of action to address some of the core issues. Now, if we're looking at enterprise, the health and social care budget within the UK is huge. When we talk about the structural challenges of Black and minoritized health and social care organizations being able to engage in the systemic racism that is within that process of securing or procuring or commissioning process, they are really, really difficult. I think you mentioned, Jessica, the difficulties that smaller organizations at community level are having across the board in engaging in that process. Then you have the structural racism within the investment kind of market in terms of actually enabling those organizations that are kind of often very early stage, often very unsustainable in the initial purposes, being able to actually scale and grow to deliver the type of healthcare that meets the needs of the communities they represent, and actually that care being given by people who actually get the people who they're actually delivering the care to, which would have a huge impact upon health outputs. I'm not sure how far your work is kind of, and I think it's coming back to that previous speaker's view around, you know, how much is the NHS or the big healthcare bodies and the tier one suppliers, how much are they being held to account in terms of diversity and inclusion? Where is the point of start? Whereas you look at racist and structural racism on the scale that you've looked at it and the determinants, it is a societal-wide problem that's very difficult to kind of address, you know, with a sort of targeted action, really, because it's so broad. And if we're looking at health inequality, then there is a way of maybe being more targeted in terms of delivering some of these sort of accountable outputs that need to happen for those structural elements to be taken out.
Jess, would you like to respond? Last one.
Yeah, just to say, I totally agree, and we heard from other organisations as well about the discrimination, racism within the commissioning process and within research budgets, etc. So I totally with you on that. I would just like, this is one report building on decades of, you know, activity and reporting and analysis. So in a way, I think if there's added value in this report, it's that it's doing this specifically from Michael Marmot, with the support and championing of those other organisations, to make the case again, or in a slightly different way for slightly different stakeholders. I don't think, and people who've been working in this area for a long time will recognise that we've, you know, got a new approach or anything that you won't recognise. But it's really just reinforcing, I think, and trying to amplify into those parts of the system which largely go under the radar a bit and don't really tackle this head on. So that's the intention of this report, I think, is to build awareness and then request or challenge organisations to take it up themselves and do far, far more. We do make the case to the national government about legislation and regulation and inspections and so on as well. But I think our hope is that this is just one part of an awareness building and strengthening the evidence base for organisations and for campaigners and advocates to use.
Thanks very much, Jessica. And that's all we've got time for today. Thank you everyone for joining the webinar, for coming on the network. Great questions, great points that were made in the chat. It was excellent to see so many connections being made through the chat as well that people are going to follow up on. That's the whole point of the network. Do come back and join us again next month when we have another webinar in this series, and do chase up the IHE report, which is available on the IHE website. It was also in the link there as well. Thank you very much, everyone.